Good afternoon. This is Tonya Howard from the Regional Clinical Performance Committee, and we're presenting this webinar, Reducing Non-Emergent ED Utilization, Best Practices for Primary Care. This is a series of 4 different webinars. This is the 4th webinar of 4. This one is focusing on avoiding the ER, role of the nurse triage, and practical office strategies. The speakers today are Barb Lindberg, who's a nurse from the Adult Primary Care Group in Essex, a UVM practice. We also have Rick Dooley, who's a physician assistant from the Thomas Chittenden Health Center and Health First. And myself, I am the Director of Quality Improvement at the Community Health Centers of Burlington. Our webinar series is now recorded and is available at the link you can see on the screen. And there is also continuing CME available for the recordings. Each one will give 1 hour of CME. The last recording, there is a nursing education credit available as well. If you do want CME or CNE credit, that will be available when you log on to the recordings. There will be a link. And once you complete those forms, you'll need to save them and scan them into email to Laura Rimmick at Northeastern Vermont AHEC, and her email is there. It's also on the CME paperwork. So just to introduce our group, the sponsor of this webinar series, the Chittenden County Regional Clinical Performance Committee, or the RCPC, is a team of cross-organizational members that's been working collaboratively to improve health outcomes in our region. We're represented by numerous clinical groups, Health First, One Care Vermont, the University of Vermont Medical Center Blueprint. We also have home health agencies, skilled nursing facilities, mental health organizations, and we do have a pediatric physician who works with us, and we do try to have a consumer on our board as well. We're focusing on ED utilization because this has been a growing issue, both nationally and among our Chittenden County region. And as you can see, there's been a significant increase statewide of 23% from 2014 and 2015, and the numbers are now out that it has continued to increase in 2016. So our work group from RCPC, the ED utilization work group, we looked there and saw that there were about 1,200 or more visits for 4 very common conditions: nausea, vomiting, diarrhea, cough, URI, and UTI. We realized that there was a lot of work in many different areas of ED utilization, and we wanted to focus on an area without duplicating the work of other organizations. So we did decide to focus on these areas of ED utilization that could possibly be avoided. And our goal is to reduce the incidence of unnecessary emergency visits by 5% in 2017. And this webinar series is actually one of our strategies to begin looking at decreasing that utilization. And now we have Barb Lindberg, registered nurse, who will be talking about reducing emergency room visits from the nursing perspective.
Hi, my name is Barbara Lindberg, and I work at UVM Adult Primary Care in Essex. I've worked at my current job for the last 10 years, and I'm going to talk to you about how the nursing perspective on how to reduce emergency room visits. Some of the information may not be new, but still important in looking at emergency room use. In 2013 and 2014, there was a comparison study that was reported in the National Health Statistics Report, and they looked at interview surveys for patients after emergency room visits, and in 77% of the patients ages 18 to 64, the seriousness of the medical problem was the reason they went to the emergency room. 12% of them visited because their doctor's office was not open, and 7% because of lack of access to other healthcare providers. Next. 5 common causes for emergency department overuse. Patients have limited access to primary care services. The emergency room provides convenient after-hours and weekend care. They provide for immediate reassurance. Primary care refers patients to the emergency room. And hospitals have the financial and legal obligation to treat emergency department patients through the Emergency Medical Treatment and Labor Act. CMS also asks us to increase our access to primary care, to reduce emergency room visits, to provide access through extended hours, through the use of medical homes, and for us to identify emergency room super users. Ambulatory care. We work in ambulatory care, and this occurs in a single episode or a string of encounters. It lasts less than 24 hours. Unlike the hospital, the patient is in control. We are merely there to be advocates and advisors. We use telehealth to communicate with our patients and other care providers. The care can occur in a wide variety of settings, from an office visit to an outpatient procedure. And we use telephone triage to give home care advice and guide access. Telehealth is much more than just telephone triage, and this is changing every day. Telehealth is the inclusive term used to describe a wide variety of health-related services delivered, managed, and coordinated, all by electronic information and telecommunication technologies, including faxes, computers, iPads, and phones. Telephone triage is an interaction that occurs between a patient and a nurse over the phone. It identifies the nature and urgency of the client medical need and determines the appropriate disposition. And we use protocols to guide the triage of patients over the phone. And we first assess for the symptoms, identifying the most urgent symptoms first, and eliminating those symptoms that may be emergent, such as chest pain, severe abdominal pain, reasons patients would need to be seen in the ER. Then we go down, once we've eliminated the urgent symptoms, we can go down to the urgent symptoms, which patients may need a same day or next day appointment. And then if the symptoms are more symptomatic in nature, then we can give home care instructions. We should always use a protocol to upgrade urgency, never to downgrade. If a patient is kind of borderline between home care and urgent, always upgrade them and get them seen today, rather than just giving the home care instructions. We use a combination of protocols, both the Julie Briggs protocol book, telephone triage protocol book, we use that, as well as University of Vermont Medical Center protocol. The plan is where the triage occurs. This is where the access is connected. Once we've assessed the patient's symptoms, then we can connect them with where they need to go, whether it be the hospital, the clinic, or we give them home care instructions. The evaluation of the plan of care may not occur in the office. It may occur in the patient's home. As we give them home care instructions, we tell them what to watch for, when to call, what symptoms to call back for. We may ask them to call with blood pressure readings, glucose readings, or daily weights. And we may schedule them for follow-up visits. We use the electronic medical record so that when a patient calls back the second time, we know what the plan was and how to use the information they're giving us now to assess their need for an appointment. We also use after-visit summaries, clinic visits, ER visits, and hospitalizations. Advantages to the use of protocols: they provide for economic savings, timely access to information and referrals, patient satisfaction, and physician relief. And in the physician white pages and telephone triage, they talked about the most common reasons patients call the office are, again, the upper respiratory, the sore throat, the cold, accounting for 13%, 9%, and 9% of the calls. And the disposition of the calls, 29% of the disposition are related to home care instructions, followed by 13% for same day or next day appointment, and 7% referral to the ER. Disadvantages to the use of protocols: there can be some liability as for both the provider and the nurse if the protocol is not clearly written or followed. Barriers include patients who do not speak English, deaf clients hard of hearing. It's more difficult to assess these patients over the phone, and this may be a time when we need to bring them into the office. Lack of access can affect how we use protocols. The protocol may say that the patient needs a visit, but we don't have a visit available, and that's when we need to become creative to try to get that patient an appointment or get them seen at a walk-in or weekend clinic. Patients may not be willing to accept triage advice. And protocols should not be used to diagnose disease states, but to provide needed care in the right place and at the right time. Of the 1,256 emergency room visits identified in 2015 in Chittenden County, 918 of these were related to nausea, vomiting, and diarrhea. And, you know, we use a protocol for assessment, and this may be assessment by proxy. We may be asking the patient or the family to look at things that we would look for if the patient were in front of us. We're looking for emergent symptoms of dehydration, mental status changes, high fever, abdominal pain associated with this. And then if that's true, then these patients do need to be seen in the emergency room. In small children under the age of 3 months with a fever over 100, they should be seen in the emergency room, and children under 6 months vomiting bile should be seen in the emergency room. We also need to assess for decreased output, either by how many times they're going to the bathroom or how many wet diapers. And the Julie Briggs protocol book does delineate assessment between, there's a child assessment for certain illnesses as well as an adult assessment. Urgent may be those patients that are doing okay at home but may need IV fluids, and, you know, are there other options in the ER like the walk-in where they can get some extra fluids that may boost them just enough so they can continue to get better at home. Education and home care instructions are important if we want them to be treated at home, if they're just purely symptomatic. You know, in its simplest form, nausea and vomiting usually resolves on its own within 12 hours. Diarrhea can take a little longer. And we also want to be listening for symptoms that are outside what we're looking at, you know, that funny little symptom that might change what we would do. It's, we think about winter in Vermont, don't forget carbon monoxide poisoning, and watching for other symptoms that might indicate that as a cause of the illness. Home care instructions can include liquids to prevent dehydration, making sure patients mix up the liquids a little bit, not just water. They can drink flat soda, watered down juices. Pedialyte has a little less sugar in it than the Gatorade or sports drinks, broth-like type soups, popsicles, jellos, things that can provide fluids. Again, to remember to encourage patients and families to do good hand washing and hygiene to prevent transmission of disease. Putting paper towels in the bathroom and not sharing hand towels. Keeping the environment clean and cleaning any toys. Handling food properly and cooking it to appropriate temperatures. And for small children to remember to vaccinate as preventative care for the rotavirus. In Vermont, we have 6,300 refugees, and many of these refugees came from third world countries where malaria may be present, and they have been taught, that if you have nausea and vomiting and a fever, you need to be seen right away to get the treatment started for malaria. So we need to educate these patients about what they need to expect in this country, and that they don't need to worry about malaria here. And this can be done through one-on-one office visits or through group visits. Another protocol that we're trying to keep these patients out of the emergency are those with upper respiratory infections. Again, the assessment is emergent, urgent, and symptomatic. We need to consider effects of chronic respiratory disease, and are the symptoms they having an exacerbation of a chronic disease, or is it truly an upper respiratory infection? Giving instructions for symptomatic treatment, and symptoms may refer to other protocols. They might be calling in with a cough, but as you assess further, they're also having chest pain, and then it may become a different protocol, different questions that we're asking the patient. Implementation and education, again, this is the referral of the patient to the right place and the right time. And it's important to know your patients, to be able to review their history on the electronic medical record. We have a lot of patients in our office that are on medications for hypertension, so we rarely ever recommend a decongestant for our patients with flu or upper respiratory-like symptoms. And in children, we need to make sure we avoid aspirin. So it's good to know your population when giving your home care instructions, and making sure we let them know when to call back. We also get a lot of calls between 3 and 5 on Friday afternoon as patients, they're starting to feel sick. They've got a little bit of a fever and a cough, and the weekend's coming, and they're afraid that they're going to get really sick. So letting them know what options are available for them to be seen over the weekend. There is a weekend clinic that our primary care site shares with the other primary care and internal medicine sites. So letting patients know that hours of the weekend clinic, how to contact them, is important when they call on Friday afternoon. Identifying a complicated UTI. In the identified emergency room visits, 95 of these visits were, of the 1,256, were identified as emergency room visits for urinary tract infections. And in our office, we see most of the patients with urinary symptoms, mostly because they have one of these risk factors with fever, diabetes, over 65. And so we as nurses do a lot of the follow-up calls after we get a urine results back. And that gives us an opportunity to teach home care instructions, preventative strategies when we call these patients back. And some of these include drinking plenty of fluids, avoiding caffeine and alcohol, avoiding holding the urine, trying to make sure people are going to the bathroom every 4 hours, wearing cotton underwear, avoiding bubble bath, and hygiene, good hygiene, and making sure that they know there are things they can do to help themselves feel better. Transition of care and care coordination management. This is the use of the information we have to assess the patient now and to plan for the future. It's how we communicate with other healthcare workers using the electronic medical record and phone contact, and contact with the patient to provide for care coordination. In the American Nurses Association white paper, they looked at the value of nurse care coordination, and the authors observed a reduction in emergency room visits, a decrease in medical costs, reduced inpatient charges, and increased patient confidence in self-managing their care, and improved patient satisfaction. In their paper, they used 2 references. One was Antonelli, Steele, and Antonelli, who conducted a study in 2008 to quantify the activities and personnel costs and outcomes associated with care coordination for children and youth with special needs. And they looked at things like phone calls, refill requests, referrals, prior auth, and they added up all these activities and the costs associated with them, and they found that the RN care coordination resulted in an 81% reduction in emergency room visits and a 63% reduction in unnecessary office visits. There also was a randomized trial of telephone care management strategy, and this was more of a health coaching strategy, which they compared a standardized health coaching with a more aggressive health coaching. And through this study, they were able to find a 10% reduction in the expected hospital admission rate. We as nurses can help prevent ER visits with transition of care management. We have a protocol that we use to make hospital follow-up calls, which can help prevent hospital readmission and ER visits. Each day we print a report that has the hospital discharges, the ER visits, and the walk-in care visits for the past 3 days. And we take this list and we look at those that were discharged from the hospital, and we try to give them a call within 24 hours. And we go over their medications. You know, have they picked up their medications? Do they know how they're supposed to be taking them? And it's surprising how many times patients will go to the pharmacy to pick up their medications. They cost too much money, and so they leave the pharmacy without the medication. And so then the follow-up call becomes a way of helping the patient acquire the medications they need to succeed. Making sure they have help at home. Either do they have enough family to care for them? Are they able to do things on their own, or do they need the visiting nurses? And has there been an order placed for the visiting nurses? What is the plan of care? What should they expect to happen? Who do they need to follow up with, and when do they need to follow up? And then any other resources they may need. We can extend this hospital follow-up call to follow-up after ER visits. And we can use that same medical report, electronic report that we run for our discharges and look at the ER visits. And call the patient, just a quick call to say, are they feeling better? Did they pick up their medications? Are they doing okay at home? And we need to remember that the emergency room does not do primary care, and primary care does not do emergency care. And so we may send a patient to the emergency room because we think they have an appendicitis, or they have chest pain to be evaluated for a cardiac reason. Well, they get that evaluation, and if it's negative, then they may be sent home without any other further testing or plan for the treatment of their pain. And so this is when it's important to follow up with the patients and get them back into the PCP office so they can further investigate their healthcare needs. The West County Health Centers, Inc. had a good protocol online that I found that differentiated their ER visits into 3 categories. A low-risk category, those patients who had their primary medical need met at the ER visit, and those were the things like simple strains, upper respiratory infections. They're not likely to need follow-up from their PCP office. There were also those who, with moderate risk, who may need some follow-up, who maybe received stitches, or they were treated with an antibiotic for a wound, and they may need to be followed up for that issue. And those with high risk, those would include the elderly and small children, or patients discharged on high-risk medications such as Coumadin or Lovenox. Those patients should certainly receive a follow-up after their ER visit. Transition of care and care coordination can occur in any time the patient tries to access the healthcare, whether it be preventative, acute, chronic care management, and patients kind of bounce back and forth between all of these. We hope we see them yearly for preventative care, but in between they may have an acute visit, or they may develop a chronic care visit, chronic condition where they need to be seen more often. So we need to help coordinate the care anytime this occurs. And there are other transitions of care, such as the transition of a child to a young adult as they're learning how to access care on their own, the young adult to a parent, as they're learning how to care for the healthcare needs of someone else, from a parent to middle-aged, or from an adult child to a caregiver of their parent. They may need your help and additional resources and education to go through these transitions of care. The things we do every day are opportunities to educate patients. The refill request becomes an opportunity for medication reconciliation and monitoring. We answer questions about immunizations. We talk to patients regarding results and what's the plan based on the result that comes back as directed by the provider. And as we get more and more into telemedicine, and patients are, getting their results online and able to email the office, it raises new challenges. We had a patient one week that they sent us an email saying, I saw my results in the computer and they were abnormal. So should I be seen at the emergency room? So we need to talk to our patients in a timely manner so that we can provide them reassurance and keep them out of the emergency room. And, patients are not patients. If they call for advice, they're hoping to hear from you within a couple of hours. In our office, we try to get back to our patients in a 2 to 4 hour time frame. And, getting back to a patient quickly can help get them into whatever primary office visit is available, or keep them out of the emergency room. And we can use the after-visit summaries as a way to guide patients' care when they call the office with questions after they've gone home after their office visit. This is what we want to prevent, this patient that's pacing in the emergency room, pacing in our waiting room, or pacing by the phone at home. While the stated reason for the trip to the emergency room may make me want to roll my eyes and smack my head, the real reason the patient is sitting in front of me in triage is worry. They are worried they are sick, worried what they have is serious, worried that they are in pain, worried that nothing they have tried has helped. The availability of information on the internet seems to have done more to escalate worry than to alleviate it. As patients look up symptoms, see the worst possible diagnosis as possibilities and feel that an ER visit is imperative. And this picture of a worried patient comes from the Emergent blog, which was a blog that was done by an emergency room visit, emergency room nurse on the West Coast. And this is what we want for our patients. As in a quote from Hippocrates, the greatest medicine of all is to teach people how not to use it. Thank you very much.
Thank you, Barb. And now Rick Dooley from Thomas Chittenden Health Center will be reviewing avoiding the ER practical strategies for the primary care office.
Okay, thanks for having me. So my name is Rick Dooley, and I am a family practice PA at Thomas Chittenden Health Center, and I also am the quality director for Health First. And for this part of the talk, we're going to talk about practical strategies for the primary care office. Maybe next. All right, and so the first question, of course, why do we care? And I know that Barb's already gone over some of this stuff. You know, ED utilization is expensive and it's on the rise. The ED utilization wasted approximately $38 billion per year now. And in Vermont, we're seeing these same trends that we see across the nation, rather, that there are more people using the emergency room for things they could be seen for elsewhere. Not only is ED care more expensive, it also leads more fragmented care. Patients get more tests. Those tests are oftentimes repeated because the results are not available when they go back to their PCP. So it just is a more fragmented system of care. And over half of ER visits are actually conditions that could be treated in a non-emergent setting. The other thing for Vermonters, of course, is that it is one of our quality of care measures for the state. So one of the things that we are graded on as practices and as health service areas is how we do in terms of ED utilization and bringing those rates down. There are a number of reasons why patients go to the emergency room unnecessarily. The biggest one is just they cannot get an appointment with their PCP. Oftentimes patients have an incorrect perception of what is actually an emergency. Sometimes it's just plain old convenience. They want to be seen after work, or they want to be seen early in the day when there's no appointments available. Sometimes it's related to just transportation issues. For those of us who have practices that are not on the bus line, it can be hard to get to us. To get to the emergency room, you can take an ambulance or get a Medicaid taxi voucher. And of course, for some insurance companies, there's either no copay or very low copays to be seen in the emergency room. Okay. All right. So looking at these issues one by one, the first is appointment availability. And in most primary care offices, schedules fill up for a number of reasons. Oftentimes just that there just are not enough providers for the patients. We have an aging population in this country. Patients are sicker, they have more chronic disease, and with reimbursements being what they are, providers are not going into primary care, they're going to specialties. So there just are not enough primary care providers. Second issue is even if you have enough primary care providers in your practice or in your area, there aren't enough on-call slots held each day for urgent appointments. The folks are booked up with their hypertension, hyperlipidemia checks, and there's not enough slots to see the folks with sinusitis or nausea, vomiting. The third issue is just a lack of effective triage. So if you start with X number of slots per day, if those slots fill up in the first half hour with folks who could be pushed out a little bit, those slots are then not available for the people who need to be seen that day. And the last reason is a big one, which is that reimbursements are low. So practices can't afford to have empty slots. The schedules need to be full. No one wants to leave an afternoon open for potentially someone to call and then discover that there's no one filling up those slots. Now, there are a number of strategies you can use to address those. The first thing, and this is different for each office, there should be an office strategy for on-call same-day appointments, and it will look different depending on what your practice looks like. If you have multiple providers versus one provider or two providers, maybe you have one provider who stays open and keeps same-day appointments for the whole day or for half the day, and the others fill with their chronics. Maybe you have folks, each provider has a certain number of same-day appointments that are kept available until that day. It's important that you plan in advance, that it's not just sort of a one-size-fits-all. There are days that are higher volume, we all know, certainly Mondays after long weekends or Tuesdays after a holiday weekend, for example. Maybe times when you want to set aside some extra appointment slots. The other thing is that providers can do everything they want, and so can nurses, but the bottom line is if you don't have schedulers and triage nurses who are well trained, so they understand how to fill out a schedule, what's the best way to fill those schedules out, then you end up filling those appointments needlessly. The second issue is patient perception of an emergency, and this is a difficult one to change. The first step is to try to educate the patient as to what exactly is an emergency. You can put literature in the waiting rooms or the exam rooms. You can talk about it. One thing that really is helpful is emphasizing to patients when they join your practice what you can do in your office. So, for example, if you do stitches or splinting, or if you have radiology or lab services, whatever it is that you can do in the office, if you can emphasize that to patients early on, then they get a sense that they don't necessarily need to go to the emergency room. You can do that anticipating when they have a chronic illness as well. So if you're seeing someone for a cough on Thursday or Wednesday of that week, you can say, if you get sick this weekend, you don't need to go to the hospital. You can come in and see us here. Sometimes just sort of preempting that makes a big difference. The second thing that helps is if you follow up with unnecessary emergency room visits with a phone call, asking why they're seen in the emergency room, and just explaining that they really could have been seen in the office. It's a little tricky to do this without sounding condemning, which is tricky. Patients tend to be a little defensive about it. But if you can follow up and say, hey, I saw you were seen for the sore throat, what's going on, make sure that you're feeling better. And by the way, did you know that we have evening hours or weekend hours or an on-call physician who could have seen you, something like that. And then the third issue is because patients often perceive it as an emergency, they need reassurance quickly. If patients leave a message for their PCP but don't get a call back for 2 or 3 hours, oftentimes they'll perceive, if they perceive it as an emergency, they will go to the emergency department. Whereas if you can call them back quickly, sometimes just having that conversation with them about, is it really emergent? Can we wait until tonight? Can we wait until tomorrow? You can avoid a lot of unnecessary ER visits that way. For patients who are seen regularly in the emergency room, our frequent flyers, having a care coordinator to work with the patient and the other providers makes a big difference. Someone they can check in with regularly, who can reassure the patient. Maybe the plan is that they call their care coordinator before they go to the ER, and the care coordinator says, okay, let me see if I can get you into the PCP or an after-hours clinic, or no, this is an emergency, you need to go. And then the last one is just identifying your high-risk patients with chronic diseases, your folks with diabetes that's poorly controlled, congestive heart failure, COPD, and make sure that schedulers understand when they need to be seen and how urgent they need to be seen, and give them a list of symptoms and signs that they need to watch for and call for an urgent appointment. So your schedulers know, okay, if my CHF patient calls with weight gain, that's something urgent, and we are going to see him in the office that day. The next issue is appointment time convenience, and that's tricky because the work environment is pretty competitive now, and patients can't afford to take off 2 hours in the middle of the afternoon to go see their PCP. There are a number of ways around this. One thing is to consider staggered scheduling, so that maybe there's providers who start the day earlier, 6:30 or 7, and get done earlier, and then other providers maybe start a little bit later, but extend their hours to 7 or 8 at night. That allows patients to come in before or after their typical workday instead of having to take time off. Evening appointments work great, but only if they're actually held open. One strategy is to make sure the evening appointments aren't opened up until 1 o'clock in the afternoon, at which point you release your evening appointments. And of course, weekends are a great time for patients to be seen in terms of convenience. There are a number of barriers to some of these changes. The biggest issue is just provider staff resistance. Most of us, for the same reason that patients work their day hours, most of us like to work our day hours, and it's convenient to have the same schedule day in, day out. And it's somewhat tricky if we're having to go in late on one morning and work late another morning, another afternoon or something. The other thing is it's difficult to adjust provider schedules without adjusting all the rest of the staffing. If you have an office that's open from 6:30 or 7 in the morning till 7 or 8 at night, presumably you have to make sure you can have office staff available, a check-in person, nursing coverage, that sort of thing. So it's a little trickier to juggle that staffing model. Third thing is that there are financial pressures requiring schedules to be full. So if I'm working late morning and going until later in the nighttime, I want to make sure that those evening slots are full. Otherwise, I could be seeing my chronic patients. For patient outreach, if you're calling patients after the emergency room, the issue is that it requires someone to call them. So someone physically needs to actually have the time to call, and that's not reimbursed time. And the last one is the trickiest one, which is that patient attitudes are just hard to change to education. You can talk to your blue in the face about what constitutes an emergency, but if they perceive themselves to be urgently ill, they will look for treatment right away. Just a couple considerations when you talk about changing your office flow. Oftentimes, if you increase the flexibility of your schedule, you can increase your revenue because the number of patients coming into you is actually more because you're seeing those acute folks, oftentimes folks who can be seen fairly quickly, so you can see more of them in a shorter period of time. And patients tend to be much more satisfied when they can go to their PCP's office instead of going to the emergency room. Cultural barriers are difficult in the office, especially if there's phone language barriers. Having access to a phone translation system makes a huge difference so that if you have folks who do not speak English or speak the common practice of your practice, they can use a translation system to communicate with you before they go to the emergency room. It is important to make sure that you have not only yourself and your nurse, but also the other staff members and your patients all understanding that the goal is to reduce ED utilization unnecessarily. So oftentimes looking at, putting data on graphs, putting it in the exam rooms or on the walls. Here's how we've done. Here's our reduction in unnecessary ED utilization. Just so everyone's aware that this is a goal that you're working on. And the last one is if you can get some data from your patients' use of the emergency room, you can look for patterns. And oftentimes when you start looking at, especially your high utilizers of folks who are seen regularly, you can see patterns that you can address beforehand at a regular PCP visit or at their regularly scheduled maintenance visit without having to have them seen in the emergency room as frequently. And this is just an example of one of the signs that UVM sees Pediatrics, and we have a similar sign in our office. Just basically reminding folks, and this is in all of our exam rooms, our waiting room, as well as our bathrooms, which is a very convenient place to put signs. That just reminds folks that we have 24-hour availability, that we have office hours on the weekends, and that the goal is that, setting the expectation that they should hear back from someone if they call within 30 minutes, so that they understand that it's not going to be within 2 or 3, but if they can wait half an hour, it'll be within that time frame. So over the last several months, we've had a number of webinars that have addressed multiple strategies to reduce ER utilization for these chronic conditions that we talked about, the UTI, gastroenteritis, pediatric issues, and geriatrics. And those CME webinars are available online. There's a web address right there. You can still get CME credit for it. There's a paperwork after you listen to the recording, and you can do that. Just sort of a quick reminder for UTIs, we talked about telephone treatment protocol and also considering using over-the-counter treatment until they can be seen by their PCP if necessary. That helps eliminate the need to go to the ER just because you have urgent symptoms. For nausea, vomiting, and diarrhea, we had talked again about phone treatment, reasons for patients that need to be seen in the emergency room versus folks who could be seen. We talked about oral hydration at home and different strategies for that, as well as using IV hydration in the office, which is a great way to avoid ED utilization. If someone who's nauseous and vomiting and becomes dehydrated, you can give them a couple liters of fluid in the office. That makes them feel considerably better. Pediatrics, there was a long conversation about health literacy and cultural background patients and working on communication tools, as well as making sure that your pediatric patients all have a home kit that they go home with. So when they talk to the on-call physician or provider, the provider can say, take your Benadryl out, take your ibuprofen out, here's the doses that you use, instead of wondering if they have the right tools at home for treatment to keep them out of the ED. And there were folks with chronic disease or cognitive disorders like dementia or Alzheimer's. There was a very good webinar on discussing the ER utilization and how to come up with a treatment plan for those folks who are cognitively impaired. So in summary, unnecessary ED utilization is expensive, it's fragmented, and has poor outcomes for patients. There are strategies that can improve access and scheduling at the primary care office, and those can significantly reduce unnecessary ED utilization. And redesigning a primary care office to improve access and scheduling involves changes in workflow of providers, nurses, and office staff. And we can't emphasize this enough. Whenever you're making major changes, it is so important to make sure that your staff is involved and everyone understands what the goal is. We're not just changing schedules for the heck of it. We're changing them to be more convenient for patients to reduce ED utilization. And if you can show data that backs that up, that's even better. Thank you very much for your time.